Erica, she's actually many things, as well as a locality pharmacist in Hull. She's emigrated from the south up north, honorary northerner. She's the co-founder of Lyria Digital Health, and she's also one of my colleagues for my One Health Tech hub in Leeds. So welcome, Erica, and we'd love to hear from you before we break for coffee.
Thank you, Louise. Thanks for this opportunity for presenting at this event. So could you please start with the first slide? Thank you. So good morning, everybody. As Louise mentioned, my name is Erica Opare, and I am the locality pharmacist for North of England Commission Support, based in Hull, and also the co-founder of Lyria Digital Health. So this morning I'm going to speak to you about why inclusivity and diversity matters in creating digital health services. Next slide, please. So first of all, I'll just start a bit about my background. So I've been a pharmacist for over 15 years now. And as Louise mentioned, I'm a Londoner at heart. I've been in London pretty much all my life, and I moved up to Hull about 7 years ago. And when I moved to Hull, it was a massive culture shock, because Hull 7 years ago isn't how it is now. London is, as you can imagine, it's very diverse, lots of different communities, and Hull isn't that way at all. And when I first moved to Hull, there were people who used to say to me, "So what are you doing up here?" Because a lot of people that weren't from Hull always wanted to move away from Hull. Leeds obviously represents the vibrant nature, the diversity of different communities and so forth, and Hull isn't like that at all. And it was quite unfortunate, because often I found myself being the only black person on my team, and also within my organisation. And when I first moved up here, I used to go to London almost every weekend, because it was quite difficult. It was a massive culture shock for me. And the reason why I moved up here was because I got married, and I moved up north. My husband was based up here at the time. So I was coming back and forth to London, and it wasn't sustainable, because I was very tired, for the weekend, and it was also costing me lots of money. And my dad on one occasion said to me, "Erica, all this money you're spending on train fares, you could go abroad with that money." I thought, "Oh, okay, yes, thanks, Dad." So then I had to really just change my mindset and really start, growing roots as to where I was. So in my current role as a locality pharmacist, I've been in this role for about 3.5 years now, and I work in commission support to my local CCG, Hull CCG. And my main role really is to look at prescribing, quality prescribing for opioids and antibiotics, and just to identify any outliers in the prescribing, and to support those practices that need help with reviewing certain patients. And the interesting thing is that the CCG serves approximately 300,000 people. We have 39 practices, over about 5 PCNs, and the prescribing over the patch isn't all equal. What we found was that GP practices based in more affluent areas didn't have higher prescribing rates of opiates and antibiotics compared to areas of deprivation and low-income households. So obviously this is a bit of a concern for the CCG, and before COVID hit, the opioid rise in prescriptions was really quite high. I'm not too sure if you'd be aware in the press. I think Steve Mosley had a programme on TV about Opioid Britain, and there was a real stark increase in opiate prescribing. So the reason why I've got this newspaper article here is, I think that's from about 2 years ago, is because I'm not sure if you're aware that in the States there was a really massive issue with opioid prescriptions, and the NHS really kind of piggybacked upon that. And I just wanted to highlight a couple of things that the report showed. That in primary care, GPs prescribed approximately 23.8 million opioid-based prescriptions in 2017, and that equates to about 2,700 items every hour. Now, 10 years ago, that was almost 10 million more items. That's a massive increase. And the unfortunate thing is that, I'm not sure if you're aware, the open prescribing data show that Hull CCG is one of the highest opiate prescribers in the UK. And this report highlighted that opiate prescribing in the north is approximately 4 times higher than in London. So it really is an issue, and also concerns the CCG. So the CCG, and the next slide, please, thank you. The CCG partnered up with an organisation, West Yorkshire Research and Development Team based in Bradford, to do a campaign called CROP, Campaign to Reduce Opiate Prescribing. This first started in West Yorkshire and involved 10 CCGs, and it ran for a year. Now, over the year, there was a reduction of 0.33% in opiate prescribing. This may not seem a lot, But over that amount of time, it equated to almost £100,000 in prescribing costs of opiate prescribing, which is a fantastic amount, and equates to about £10,000 per CCG. So it's a fantastic cost saving. So in our locality, I run the project for over 4 CCGs in the Humber region. So it's Hull, East Riding, North East Lincolnshire and North Lincolnshire. And this run for years. So what it involved is every practice that joined in this project was sent bi-monthly reports, just showing in terms of the breakdown of their patients. For example, if you're on high-dose opiates and if you have a mental health diagnosis, those are the risk factors, because we know that the longer you're on opiates, the longer it is actually you're going to cause some sort of, you're addicted, unfortunately. And try to explain that to certain patients that, you've been on your opiates for 10 years, 5 years, so that you are addicted. So what we did was we then looked at the data as to how can we then further identify what patients need more support. Now, GPs are already stretched, so these consultations are very complex and it's more than the standard 10 minutes. Now, in one of the localities, we found that some practices had above average levels of opiate prescribing. Now, these practices were situated by the coast. So when we drew down the data and had a look at it, we found that the demographics showed that patients over the age of about 60, 65 were retiring to the coast and subsequently taking their opiates with them and bumping up the numbers. It's almost these practices were inheriting these problems. So what happened was, this obviously was a city council problem as well. The city council then saw some funding and then created some services within certain practices to be able to identify which patients needed more support. They then got nurse specialists to come in-house and then subsequently run these reviews. What was happening was, when we identified some patients that were obviously had a problem, they weren't attending to these referrals. There was a bit of a stigma that, I'm going to an addictions clinic. So this actually worked really well, bringing the resources in-house, thereby the patients had the mentality that they're going to a normal appointment and to be reviewed in the medication. Now, working with this data really sparked my passion for tech. As my background is in pharmacy, a healthcare professional, I didn't know anything about the tech sector. So I was thinking, how can I get into tech? So as you do, you take to Google, and I was just Googling things, how do you get into tech? And I came across this organisation called Empowering Women with Tech. It was based in Leeds. So I thought, okay, I'll go to the event. And it was nice to go to Leeds because it's completely different to Hull. It was very diverse, it was a vibrant, atmosphere. And after I left the event, I just left feeling really empowered and inspired and just really buzzing. And they were announcing they were actually having a mentorship scheme. I got home and then I just quickly enrolled, and I didn't hear anything for a couple of weeks, and then I contacted them again, and I'm glad that I really persisted, because in doing that I partnered up with my co-founder, and she's actually an amazing person and also my tech mentor as well. So it was an interesting journey, because from actually working on this project, I was thinking, how do I get into tech? And next slide, please. Next slide, please. Thank you. Thank you. So as I said, I'm the co-founder of Lyra Digital Health, which was first started a couple of weeks after lockdown measures. And our first offering is going to be centered around the menopause. Now, when I was looking for images to represent the menopause, I wasn't really happy with the images that Google was churning out. It was pictures of women over the age of 50 just looking tired, drained and despondent. I thought, no, that is not good. The menopause, every woman is going to go through this. And, it should be celebrated. Change is a good thing. And one thing that is quite sad, that, menopause is seen as a bit of a taboo. And this is something that my co-founder and I are really passionate about, changing how menopause is seen. And we really want to innovate, services and products to empower women to be able to go through this change and feel happy and well. So next slide, please. Thank you. So why is it important when designing services, we include and engage as many people that are most likely to use these services? So for me, and I'm just going to sum up in 3 reasons, is the first thing, it sparks innovation. And I'm really passionate about innovation. And I've read a lot of different articles and listened to podcasts. But one definition that really rang true was that innovation is the way of transforming smart ideas into products and services that simply make life better. And that's what we want. We want to make life better, more so now in these really unfortunate circumstances. And I've come across many exciting and tech innovations and solutions because of really the fact that sometimes when you push to, in unfortunate circumstances, amazing things happen. And when you look at the symbols for innovation, it's almost like a light bulb or a spark. And for a spark to really happen, you need to get the right ingredients. So the right ingredients are really getting as many people that are going to be using these services so they can access and make their lives better. Now, the second slide, please. Thank you. Thank you. Now, the second reason as well is that we want to capture the underrepresented and often forgotten members of society. We know there is a huge data gap, especially for women, especially women from ethnic minorities. And I was speaking to a gynae and a menopause specialist, and she mentioned that in her clinics, women from ethnic minorities highly access women's health services that compared to their white counterparts. This is mainly due to culture. My co-founder and I, whilst we're trying to create our first offering centre around the menopause, we've held various focus groups and studies with the intention to hold more, because we want to get people's stories, we want to get women's stories, just to really understand how they live and how they access services and how the menopause is really impacting their lives. I was listening to a podcast and a GP was talking about, her personal story. She went to visit her aunt and her aunt hasn't been too well. Now, this GP had a special interest in women's health, so maybe her line of question was more based in that narrative. And she was asking the auntie, I think the auntie was in her early 50s, about 52. And the auntie was saying, I'm not feeling well. And so the GP asked her, so have you been experiencing any hot flushes and so forth? And then she said, well, I live in India. This is, 40 degrees Celsius. What is hot flushes? And, so that was obviously from a cultural point. And unfortunately, the auntie suffered a fall and she was prescribed steroids. Now, we know that women going through the menopause, there's a higher risk of osteoporosis. So if you're prescribing steroids, that further increases the risk. So she then ends up in a wheelchair. And then long after that, she passed away. And this is a really tragic, ending to the story. And this really hit home because my mum suffered really, really badly with her menopause symptoms, but she never accessed the GP. So this is quite clear because also with the focus groups that we hold, that we know that women of ethnic minorities do not access health services based purely because of the culture. The third slide, please. The third reason is that inclusivity creates real change and it benefits everybody. Now, when one person isn't well or isn't healthy, not only does it impact them, it also impacts their livelihood, those closest to them, their families and their friends, and also their community. And COVID obviously highlighted the importance of community. Communities come together to make up the population. Health is more enjoyable as a community. And I believe that creating digital health services that includes everybody that people can access can also be a massive cost saving, not only in prescribing costs, but also to the local economy, because people are willing enough to go to work and therefore not staying at home. It has further highlighted what needs to be in place for healthcare services and the requirements for people that need these services. So for me, these 3 points, just to summarize, is that it sparks innovation, it ensures everybody's included, and health is more enjoyable for everybody. So thank you everybody for listening, and I know it was a bit of a whistle-stop tour. I could just go on forever because my passion for tech is really immense, obviously coming from a healthcare professional background. So thanks, Lou. Thank you.
Thank you, Erica. That was great. You covered so much content. It was fantastic. And, it's funny, Indy Singh yesterday, he also touched on cancer patients from ethnic minorities who present much later because of the stigma, because they just don't go to the doctors. So it's interesting that you raised that point as well. It's very sad, but thank you again, Erica. Lovely to hear from you. We are going to have a 5-minute coffee break because we're running slightly over.